she's here. Dr. Babatope, can you?
Here. Did you hear me?
Yes.
Okay, thanks.
Dr. Chapa? Dr. DeFilippis? Dr. Farmer?
Here.
Dr. Goodman?
Here.
Dr. Harper?
Here.
Dr. Ibrahim?
Here.
Trina Ida? Lee Johnson? Dr. Keller?
Here.
Dr. Lakey?
I am here.
Dr. Martin?
Here.
Dr. Martinez? Dr. Maxwell?
I'm here.
Elizabeth Mayer?
I'm here.
Dr. McCullum Smith?
Here.
Dr. Mitchell?
Here.
Dr. Nemiroff?
Here.
Dr. Newport?
Here.
Brittany Nichols?
Here.
Dr. Oliphant? Dr. Olvera?
Here.
Dr. Pliska? Dr. Raji?
Here.
Olga Rodriguez?
Here.
Scott Shutlin?
He is actually out today and will be absent.
Okay, thank you. Sue Shell? John Scott?
Here.
Dr. Suarez? Luann Southern?
Good morning. I'm here.
Thank you. Dr. Thompson?
Here.
Dr. Wagner?
Here.
Dr. Wakefield? Dr. Williams?
Howdy.
We have 25.
All right, we have 25 people, so we are above quorum. So we're ready to go. Thanks everyone for being here today. I know you guys are very busy and it's a very busy time of the year, but thanks for being part of this meeting for the Texas Child Mental Health Care Consortium. We have a pretty full agenda, so I'm going to move pretty quickly through things today. But again, appreciate your time. First thing on the agenda is the approval of the meeting minutes from the last executive committee meeting. People will take a look at it, and then I'll need a motion and a second to approve them.
So moved.
Second.
Right.
So I thought that was Dr. Ibrahim, and then who was the second?
Babatope.
Dr. Babatope. Any further discussion? Hearing none, all in favor, signify by saying aye.
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 Opposed? Opposed, nay? Anybody?
Excuse me, Dr. Lakey. Sue Shell has joined.
Okay. Yeah, anybody voting nay? Anybody abstain? Then let the record show that we have unanimous approval for the minutes. So let's go. We're going to spend a little bit of time talking about the legislative session. And yeah, if we can go ahead and put that in full screen. So I want to spend just a little bit of time letting people know where we are related to this legislative session. And then we have time for questions. Obviously, we're right in the midst of it. And things are pretty busy. If we can go to the next slide, please. just some basics of kind of where we are in the session. The session started on the 14th. Sine die, when everything ends, is on June 2nd. So we are day 77 of 140. So a little ways past midpoint related to the legislative session. And they have been very busy. The House, there's been 6,610 bills that have been filed. On the Senate side, there's 3,513 bills that were filed. We're past the date of when you can file any more bills, but adding that together, we're a little over 10,000 bills that have been filed for this legislative session. That is a new record for Texas by a significant amount. And just how busy a lot of our GR people are across our university systems. I was talking to the people in our GR group earlier today. They're having to follow about 32% of those. And so a little over 3,000 bills in our university. And I know that's probably the same at your universities. And so a lot of activity taking place. Their bills are being heard on both the House and the Senate. We're starting to see the point where bills are starting to cross over, but again, a lot of work that needs to take place. The only bill that has to pass is the Senate bill or House Bill 1, the budget. But again, a lot of additional bills are going to move forward. I can't go through all those bills, but I thought a couple of highlights that would be of interest to you, I would spend a little bit of time talking about today. If we can go to the next budget or the next slide, please. It's about the budget for the consortium. So in this slide, you have data that we've presented to both the Senate and the House. We had a hearing in February on the House side, and we've been providing additional information to the Senate related to our budget. In the second column, you have the amount of money, and it was on the same on both House Bill and Senate Bill 1. And then you see the requests in the next set of columns. In the next second to the right, you have the differences between what was introduced and the request for the consortium. If you added everything together for the consortium, we were at about $380 million. There's additional ARPA dollars that has carried forward. That's not included in that. And so we're working right now on that delta there of $98 million. And the information that we have received is that the real work related to our budget is going to take place in conference committee. And so they have voted out their budgets. That $98 million is in what we call Article 11. And so they're able to discuss it, but there'll be a lot of discussion over the next month related to the amount of that that gets put into our final budget. The differences between what we asked and what was introduced is the work that we've done with ARPA. And so if you look through that, there's about $27 million related to TCHAT, where we were able to get into schools quicker because of ARPA, that we were able to do a little bit more research with some funds that we were able to pull together. There's people that we've had on our team and in internal evaluation and communications that were funded with ARPA that we would need to have put in. And then the funds for Peripan, YAM, and collaborative managed care, all of which we think are important, along with the workforce initiatives that you guys have put together. Those have been funded by ARPA, and that's part of the decisions that will have to be made over the next month. And so again, we will continue to work very closely with the legislature. Our request to the members of the consortium is that during this month, you may get a text from me or a call from me or somebody from my team saying that we need some information very quickly. And it's because conference committee has started and we need to get the data to them as quick as we can if they have some additional question. Okay. Any question on that? Let me go to the next slide. So, Luann, I see your hand.
Yeah, good morning, Dr. Lakey. Just a quick question. Are you going to request that a dollar for dollar replacement of ARPA dollars with GR? Is that your plan?
So the way that it's working is that there were projects that we started with ARPA. We piloted projects and some were very successful, some were less. We worked with all the members of the consortium to identify the priorities. The priorities we have listed there, the workforce, peri-pan, YAM, and collaborative managed care. And so we're requesting the dollars to not backfill. We worked with the legislature to identify these items, but when the ARPA funding goes away, they will need to have GR to continue on those initiatives. So all these requests here are for general revenue to continue these programs.
Okay, thank you.
Yep. So there is a new rider that's on the budget, the adopted budget in both the House and in the Senate. The first part of this rider is the same as it has been before, but I'll draw your attention to the second part of the rider. The Texas Child Mental Health Care Consortium shall explore opportunities for third-party reimbursement for any other necessary services delivered beyond 4 TChat sessions or to address any broader needs, including through Medicaid, CHIP, or a private plan or a school-based reimbursement. So we will have work over the next several years where we'll need to bring people together and see if this is possible and see what the benefit of building Medicaid or third-party insurance would be beyond the initial 4 visits through TChat. And so that will be part of our work through the consortium over the next several years coming after this session. If we can go to the next, there are several other riders on the budget that I thought you would be interested in. One that's adopted by Representative Perry in the House. It'll put $5 million into community colleges to develop the mental health workforce. This isn't a Texas Child Mental Health Care Consortium rider. We're not eligible to apply for these dollars, but it will help solve some of the challenges we have, and there may be opportunities for some partnerships there. Some of the riders that are in Article 11, again, those aren't, unless they get moved into Article 3, won't necessarily happen, but they'll be discussed during the conference committee. One, Representative Sweener, looking at the success of CPAN, would like us to look at whether we could provide substance use guidance through CPAN and do that in a pilot. And so there's $4 million that will be available if that rider actually gets adopted. Second one that I know members of this group would be interested in, Representative Rose has 2 riders. One would increase the funding for the forensic psychiatry fellowships up to $9 million, which would be the amount of money that they need to continue to be at the steady state. And then there's a rider to expand psychiatric GME by $8.1 million. It gets in the House, not in the Senate, and again, would need to be adopted by both before it becomes finalized. If we go to the next. I wanted to bring to your attention House Bill 18. This will be a priority bill from the Speaker's office. It has a very low number, which means it's a priority bill. This is a bill by Chairman Van Dever. He's the chairman of the Public Health Committee. On the Senate side, it looks like Senator Perry, his office will be carrying it on the Senate side. And it's a big bill whose focus is on improving the stability of rural hospitals in the state of Texas. And so it does several things. Many of them aren't applicable to this group. And there's a strategic plan related to rural hospitals that codifies the State Office of Rural Hospital Financing. Something I think is pretty cool is this Texas Rural Hospital Officers Academy. It will set up to 4 entities across the state of Texas that will be working with rural hospitals to teach individuals that get put in leadership positions, how do you run a rural hospital? How do you do the finances? What are those opportunities out there in order to bolster the overall expertise of the executives running rural hospitals? What I want to bring your attention to is the items on the bottom. And this, I've taken this language out of the fiscal note, and the reason I've done that versus the bill itself is because there's a committee substitute, and then we've worked with them again for some additions to the community substitute, so we haven't seen the final bill. But there's several things that will involve the consortium. One thing that will involve the consortium is that they want to bring CPAN-like support out to rural hospitals. And so if there is a child that's admitted to a hospital and the physician taking care of that child in that rural hospital wants to call one of our medical schools, that's part of the consortium, that they will be able to get that kind of support similar to CPAN. Second part of this is that over the next 2 years, they will direct us, the consortium, to develop a plan to enhance support to rural hospitals across the state of Texas. There's a defined definition of a rural hospital being in a county with less than, I think, 67,000 individuals. But they will ask us to develop a plan of what we could do, looking at T-Chat-like services to those rural hospitals. We have, again, been in good conversation. And again, I appreciate several members of this committee that I bounced information off of, but they're putting in language so we can control the hours and make it manageable, but again, will allow us to plan over the next several years before we would get the approval to move forward. But the third thing that it does that I want to make sure that you are aware of is that there will be dollars put in to the Higher Education Coordinating Board's budget. They then go to the Health and Human Services Commission, Rural Health, to partner with the 12 members of the consortium to develop pilot projects on how you could support rural hospitals. The exact amount of money is not defined yet, but I think it will be substantial. And with those dollars, a variety of pilots, and they plan to do this pretty quickly come this fall. These pilots would be developed. You will work with our team here so that we can learn those lessons. And then that would be part of the planning related to the long-term plan of how we support rural hospitals in the state of Texas for kids that are there that with mental health needs. Let me stop there, see if there's any questions on that bill or any of the riders I discussed. Luann, I see your hand.
Yeah, so in terms of the rural hospital part and the CPAN-like services, so many rural hospitals don't have children's psychiatric units. So if a young person presented to one of those rural hospitals that required an inpatient stay and they didn't have access to a child psychiatrist, is that sort of a scenario where you would envision a CPAN-like service providing support to the hospital in terms of that consult, or do you have any idea like what they're envisioning in terms of that support to those rural hospitals?
So the way the committee substitute is initially, or well, the current version is written, it would be very much like CPAN. And so you would be providing guidance to help to make sure the right diagnosis is made, and would allow, and you would use the expertise to identify services in the community that could be helpful to that hospital in navigating the care of that child. It doesn't mean that our institutions take on the care of that child. It would still be a CPAN model, and we've had a variety of conversations to make sure that it stays in that CPAN model, because there are issues such as credentialing, et cetera, we want to be very careful about. But again, it would be a CPAN-like support for those hospitals, but not taking on the direct care of that child. Now, and under
Okay.
the chat, we will plan for what that looks like. And yeah, I think, talking to the folks at HHSC, there are several hospitals that they would like to be able to dedicate a room in their facility for kids with mental health issues to be able to come and get mental health services. And so something very like T-Chat. But we'll need to work closely with a variety of partners to make sure it's done in a way that is doable for our HRIs and doesn't make them assume certain services that they wouldn't be able to provide. For example, in the statute, we were able to work to make sure that there's language related to the hours of operation and that type of guidance there, so that we're not so we're not doing night call, so that we're not doing, it's something that was very important. Steve Pliska, talking to him, so we don't get pulled into medical clearance of individuals, but at the same time provide real support to the hospitals in a way that they can't get right now.
Well, just in the loop as well, because we have many children in DFPS custody who live in rural areas and often do present at those rural hospitals. So I would love to learn more once this progresses through the session. Thank you.
Thank you. And so, the other part of this is something that we'll need to think through is, when we partnered with T-Chat, we brought in TEA and the educational service centers. There might come a time where we bring in some expertise from rural hospitals as part of this meeting to make sure that we're working effectively with them. Let me go to Olga, and then Cheryl, I'll go to you.
Good morning. I just wanted to figure out how, I just want to make sure I understand how the method of finance swap with our existing funding is working, and if this is new money, how is that all working together? Does that make sense?
For the budget for next, for the budget, yeah, there will be guidance on. Actually, you want to jump in? Alex, I just want to make sure that
Sure.
my explanation is consistent with your explanation.
So for existing programs, the method of finance will become GR eventually for all programs that are approved to proceed.
If approved, right?
Right.
If approved.
We do have an ARPA extension on the table, so as long as you have ARPA funds, you will have access to them to keep using them on those ARPA specific programs. Again, if we're given authority to continue doing those programs. For these other pieces that Dr. Lakey is mentioning that will be on a rider, that will be separate GR funds that would be part of a pilot project. So it will still be GR, it will still be coming from the state, but it won't be part of the base budget.
So am I to understand that there's essentially 3 buckets of money? First, it's whatever ARPA funding is in the current supplemental bill for this biennium still. There's the method of finance ARPA funding for the next biennium. And then the third is for these additional CPAN and TChat like activities with rural hospitals, that there will be additional, there's a fiscal note on this, so it's additional GR for that. So like 3 buckets, right?
Yes, that'll be additional GR. There's not going to be additional ARPA. It will just be what is existing, your existing balance that you will have access to.
Right, but from a legislative standpoint, I'm just confirming. So we have the supplemental bill that we're watching for use of remaining ARPA funds in this biennium. Then we have a request for method of finance swap from federal to state funds in the next biennium. And then we have new GR requests for new activities in the next biennium. Is that correct?
Sure. It's not our GR request. It'll be just part of the rider. So if we're instructed to do it and we have the funding to do it, that will be the funding mechanism, will be additional GR.
Okay. Thank you for that clarification.
All right, Cheryl?
Hi, morning. So I know this forum is only talking about the Texas Child Mental Health Care Consortium. And so this forum would be addressing a pediatrics part of child mental health in rural hospitals. Is there a parallel system for adult mental health, or is that something outside the scope of this meeting?
The House Bill 18 is focused on kids. It does not have an adult component as part of that bill. So I think they're looking at different ways to address more of the adult issues, but that's not part of what we will be tasked to address. Okay.
Thank you.
Yep. Thank you. Any other questions?
Dr. Lakey, can I just ask a clarifying question?
Yes, Shannon.
I think, and maybe I misunderstood, I think Olga was referencing use of ARPA through this biennium, but actually ARPA can be used beyond this biennium. So just want to clarify that.
Yep.
And do you all have line of sight as to how long, if the extension is granted, ARPA funds are able to be accessed?
Alex, you've been in those conversations.
So we have an extension, that's true. And what we just communicated out to the HRIs is that the funding would be accessible through August 31, 2026.
Okay. Any other questions? Alex, let's transition over to you related to the budget change request process.
Okay.
that.
So hopefully you all have seen your PIA agreements. That's your contract between UTS and your own HRI. Within that, there are some instructions about if you're needing a budget change or a project change, you can complete those through a project change request form, which is also included in the backup of your PIA. And in that, you will kind of explain what it is that you're trying to do and what your financial situation might be if you're looking to offset expenses, or maybe you are requesting new funds or whatever it might be. But before you make any changes like that, we ask that you submit your project change request to myself and Rachel Jew, and we will take a look at it. We will discuss with leadership if necessary, or get with you. And from there, we can work on those requests. But we do have a process for that, so please follow it.
Any other direction? Then any other direction regarding the current biennial budget?
Sure. So I think you've probably all heard Dr. Lakey speaking about having GR funds lapse. Previously, we might have said, let's find a way to use these funds, but the direction is to have unused GR fall back to the state as part of this biennium. So we're not necessarily seeking new or additional activity to spend those GR funds if you aren't naturally spending them on direct services.
We're trying to make sure we hold as much as possible to the budgets that were approved. There are things that come up in order to make sure projects that were approved before are whole. We want to make sure things that were approved that were whole, the previous approved are whole and can move forward. But we're going to be very careful about new ideas, et cetera, in the midst of everything that's going on with the conversations with the legislature to make sure that, again, we're doing our financial stewardship to the level that they want. And so we're going to be careful with any new projects right now, even if there's dollars in your budgets that have not been spent. One of the nice things that the legislature has done is that they've trusted us to say that they've funded us to the level of the possibility of getting out to all the schools, et cetera, with the understanding that if there are more budgets than were needed, that we would pull those back and give them back to the state as they then build our next budget. And so we will, I know there's several people that have ideas and would like to talk. We're happy to talk. But again, we'll just letting people know that we're going to be very careful right now to make sure that the dollars really are aligned with the pre-approved plans. And the reason that there's dollars that lapse is not the fault of the HR. It's just sometimes it's hard to hire people. The programs take a little longer to come on board, et cetera. That's understandable. We just want to be very transparent with the legislature related to the funds, because you can see in the budget, it's a lot of money that they've entrusted us with, and we want to be very careful with those funds. Any questions? All right. Let me divert from the agenda quickly. There's been several members of the executive committee that have joined us since we started. Nago, you want to gather those names?
Sure. So I believe Dr. Martinez, you're on. If so, can you get off mute and say here?
Here, no conflict.
Okay. Elizabeth Mayer.
I'm here.
And let's see,
Dr. Chapa, I believe you're here.
Dr. Chop. Yep.
Yep, Dr. Chapa is here. Thank you.
Suarez is here too.
Dr. Suarez.
Okay. And Dr. DeFilippis is here.
I think she identified earlier.
Oh, shit. Okay.
Okay. Sue Shell. Sue, did I see you?
Yes, here.
Okay.
Thank you.
So I think,
And Dr. Wakefield, you're here.
Yes, hi.
All right.
okay, thank you.
And Dr. Oliphant, were you able to join us? All right. And then Trina Ida and Lee Johnson. Okay.
Okay.
Very good. All right, we're going to transition now to the, let me do something real quick here. To a couple of updates related to the consortium and on our programs. One update that I wanted to provide the executive committee has to do with the role of our program medical directors. Again, I want to thank the individuals that are medical directors here. Laura Williams has been a medical director of CPAN. Sarah Wakefield, medical director of PeriPan. Steve Pliska has been the medical director of CPWE. We have decided that the other workforce initiatives, especially the fellowships, that we needed some additional attention, and we're delighted that we could talk Dr. Adam Brenner into helping us coordinate those activities. Dr. Brenner is probably already known by most of the executive committee. For those of you who do not know him, he is a distinguished professor at UT Southwestern. He gives guidance for their fellowships and their residency programs. He's the Vice President of Education and Psychiatry. He's the Director of the Adult and Residency and Training Programs, and has a distinguished academic history, and has been really helpful as we've tried to help our institutions figure out how do we keep residency programs up and going, develop new programs, and we're able to get him to cut out a couple of percentage of his already stacked percentages for his FTE at UT Southwestern to help give us some guidance so that we can bounce questions off of him and he can give us a little bit more support. We're going to be leaning on the medical directors a little bit more over the next year for several things. We have been working to get some additional performance guidelines put in place, looking at best practices in a variety of areas. Sometimes there's problems that we need to resolve, and it's good to have somebody that's a medical director at one of our institutions to lean upon as we develop standard training materials, when we're working in conferences or doing a variety of things. I won't go through the whole litany of what we ask them to do. But I did want to spend a little bit of time just thanking all four of them for the commitment, because we use them a lot, and we're going to be using them more as we try to be as evidence-based and data-driven as we can on the variety of programs that we're using here. And so if one of them calls you or on our behalf, please work with them, because they're doing things we've asked them to do to drive up the quality of the various programs of the consortium. Any questions? Again, Adam, welcome. It's good to have you here. And as I noted, you are extremely well known in medical education, and appreciate you donating some of your talent and time to our initiatives.
Thank you, David. I'm very excited to be joining this, and look forward to talking to many of you individually about opportunities to coordinate and collaborate in education. Thank you.
I think later today, we'll be talking about some of those activities where he's already been instrumental as we've tried to leverage support across systems and across universities to help some of the smaller universities do things that they couldn't do without support of the other universities within the consortium. And I think that's part of what we're trying to do, is helping all systems, all universities succeed. And workforce is one of those areas where you need some additional time and expertise to help support the universities. Luann, I see your hand.
Yeah, I was just going to say, in terms of what we know about children's behavioral health evidence-based practices, I had the opportunity to participate in the UT Houston day meeting about the latest research on children's mental health disorders and use of psychopharmacology. And I think a lot of our systems that are involved, the HRIs, have some incredible expertise on what research is being done in their institutions and on the application of evidence-based practices for children's mental health. And just want to put a bug in everyone's ear that it would be a wonderful thing if we could have some sort of a gathering similar to what T Health Houston did amongst our HRIs that are involved in the consortium to really talk about some of those things that are happening that are very exciting in terms of the field of children's behavioral health care.
Very good. Thanks, Luann. Let me transition now to our workforce initiatives. First, an update on CPW. Dr. Pliska?
I can't hear you, Dr. Pliska.
So I've just recently attained the title of the sort of the medical director more formally. Prior to that, I was mainly just the chair of the work group. So pursuant to that, I've had a series of meetings with all of the HRIs. I'll complete the last in the next to kind of get an in-depth view of their programs and help the CPW work group kind of develop more goals and objectives going forward. Generally, those meetings have gone very well. There have not been any unusual difficulties. I think most people's partnerships with their community agencies are going very well, and residents are having good experiences. There's a moderate degree of diversity or variation in the types of experience that residents are having, and that's all to the good. But I'll be able to report on that more specifically in terms of the kinds of things that people are doing. So I can give the executive committee kind of a more formal report at the next meeting, since I'll be able to collate all this data that people have been providing. Another important development is that a variety of HRIs have applied and been accepted to participate in the pilot program for transitioning patients in the TCHAT program into the local mental health authority clinical programs. So Rachel Jew's been very helpful in keeping that process on track, and all of the acceptees have been notified, and we'll be setting up meetings for them to start operationalizing the procedures by which that can be done. And we should have a more detailed report on that at a coming meeting.
Very good. Rachel, anything you want to add?
I can share the awardees for the LMHA pilot. So we did, you all approved as part of this plan that we would select 3 to 5 LMHA and HRI pairs to participate in the pilot. And we have selected 5 pairs. That includes UT Health San Antonio, Center for Healthcare Services, and Center for Healthcare Services of the LMHA, UNT Health Science Center, and My Health, My Resources of Tarrant County. Texas Tech Lubbock is going to be participating with 2 LMHAs, StarCare Specialty Health System and West Texas Centers MHM, and UT Austin Dell will be partnering with Central County Services.
Okay.
Just a quick CAP update. Again, welcome, Dr. Brenner. UT System will be, working closely with Dr. Brenner over the coming months to kind of get things ramped up with that medical director support for our CAP and other workforce initiatives.
So on this pilot with the local mental health authorities, again, my thought on pilots is, pilots don't continue forever. We do them, we gain information, we're transparent about that, and then we, using that information, coach other partnerships across the state. And so I appreciate the institutions that are willing to be on that front line during the pilot period. But I would also encourage the rest of you to watch related to the information that's gathered from that pilot. It has been a challenge for many of us related to kids that are in the TCHAT program and figuring out how do you transition their care to a provider. And many times the only provider is the local mental health authority in that community. And so working with them, but also with HHSC and others to figure out the policy barriers, and how do we resolve those policy barriers and share that widely, what will be really important. But again, just for those that were not able to be funded, stay tuned, stay involved in this conversation, because this pilot will not be, forever. It will be gathering the information and then translating that to other places. Olga, I see your hand.
Yes, Rachel and Dr. Lakey, can you remind me what the process that was used for selecting the sites, please?
Yes, so we held, Olga, a pre-application interest meeting, and following the meeting, we released an online application. It was a short application. We just asked that folks make sure that they're connecting with their LMHA. HRIs were responsible for submitting an application. From there, Dr. Pliska and I reviewed the applications and then brought them to the TCHAT LMHA work group. And Dr. Lakey notified the applicants last week.
Thank you.
And can I just make a clarifying point? Dr. Lakey did mention the HRI and LMHA pairs that were funded. Just want to make a correction that we are not attaching any funding to this pilot. Just want to make sure that that's clear.
Sorry if I used the word funded. Yeah, they were selected. Good clarification. And I would request anybody that speaks in the meeting, I need your cameras on just to be compliant with the Open Meetings Act. Dr. Pliska?
I just want to give thanks to Dr. Rabateau and the folks at UT Houston and Harris Mental Health Center, because they already had a bit of a process going that really they had worked out a lot of details, and we didn't have to start from scratch. That was able to really kick things off, and I think we moved much faster than we otherwise would have been able to move. So I just wanted to recognize Dr. Rabateau and UT Houston.
Thank you so much, Dr. Pliska. Thank you so much for your leadership.
Any other questions on CPW, the CAP, or the pilot? All right, hearing none, let's go to the update on PeriPan.
Hello. I'm not sure if I should wait till it goes to presentation mode. Perfect. Great. Thank you. All right. Happy to give this update on PeriPan. Our enrollment, we have over 1,000 OB-GYN physicians enrolled in PeriPan as of the end of February. We are seeing a tick up in our OB clinics. And next slide. So this is our general slide that we show each month. Wanted to show that we had we were excited about seeing the growth after our lower in December for various reasons, holidays, those kinds of things. People often aren't going to appointments. But we have seen continued growth as we like to do, or as we're really excited about in PeriPan for February. So that is our highest month. We continue to see growth in our first-time callers and in our multiple callers. So we're finding that we hope this data represents that people are finding the service useful and are also newly discovering the service and responding to our efforts to educate the population about this service. Most people are continuing to call about a specific patient. Most people are still calling to try to figure out where to send a patient and how to get them help. And many are calling about next steps in medication, if a medication is appropriate. And so we are continuing to provide services around that. Next slide. Physicians continue to be our #1 caller. When we break that down further, as was a previous executive committee request, so we have continued to do that, we see that our obstetric colleagues are #1, pretty by far caller, and then followed by our pediatrician colleagues, followed by our psychiatry colleagues, and then our family practice colleagues. So I think that was somewhat surprising. That our psychiatry colleagues would be calling as much as they are, but we're really excited to see that and to see that as a resource for psychiatry colleagues that are out there that might not feel like they have the expertise, but are already treating a woman in the pregnant postpartum phase and are able to utilize PeriPan to keep that woman in her current treatment level of care. So we're really excited about that. We continue to have a lot of residents, a lot of trainees calling, and we're working on clarifying who those residents are, if they're obstetric residents, pediatric residents, psychiatry, family practice residents. So we'll have that data forthcoming for you guys when we make a little shift in how we're collecting that data in trait. We are, but overall, 64% of those who are calling PeriPan are physician colleagues. Next slide. When we look at consultations by type, we have seen some difference in the last couple of months. We have always wanted to really, when we look nationally, about 2/3 of calls tend to be handled without getting the psychiatrist involved, with about 1/3 of the calls being handled, having that call transferred to the reproductive psychiatrist. That is in concert with the rest of the nation, but we have seen an increase in PeriPan, which we're really excited about. The reason we're excited about that is that it is that piece of talking with the psychiatrist that drives the physician change in the future. So when we're thinking about access projects as a capacity building behavior change mechanism for our frontline clinicians, we have seen through data collected in other states and research done in other states that it is that discussion between the clinician and the psychiatrist is the catalyst for that change behavior and that increase in capacity building. And that's how the access project becomes more than a referral line and really a behavior change mechanism for our frontline clinicians to increase capacity over time. and increase that expertise. So we're really excited when you look at January and February that we've had a dramatic increase, really, and above what we would expect nationally, looking at the national standards for the number of calls going to our psychiatrist. And I want to call attention and thank our teams for this, because some of this is in the language and how this is offered and how this is discussed. And when someone calls in, to really get that call over to the psychiatrist. So great job, teams, in increasing this percentage. We would expect that this is really we'll see dividends from this in the future for that change behavior and capacity building in our frontline clinicians. So 55% is really exciting for February. I'm not sure the expectation should be to sustain that. But anything above 33% is great, and I hope I would love to see it sustained at this higher number. Next slide. The second thing that we see that really drives change behavior and drives the excitement and trust in that relationship is the ability of the Access Project to see a patient one time, to clarify the diagnosis, clarify the treatment plan, and provide that information back to the frontline clinician. So if they're super busy and they're not sure what to do, but they're willing to keep that patient in their practice and provide them treatment, that the Access Project helps to make sure we really have clarified that diagnosis through a one-time telehealth direct consult. And so this is another thing that's being offered through PeriPan. And we want to, and our teams are offering that. And so more and more we're seeing that happen in PeriPan. And we're excited to see this increase pretty sustained in this 15, 14, 13 level. We'd like to see it even higher and grow. This takes our, the call to get to the psychiatrist, and then the psychiatrist to think that it is necessary, and then to recommend it. And I'll tell you that it's a pretty complex process that then after recommendation, the clinician, the frontline clinician has to accept this. They have to talk with the patient about if they want this. Then they have to set that up to a time that the patient's able to be seen. So it's a fairly complex process, and I really want to also draw attention to the work that teams do to make this happen, and how in addition to talking directly with the psychiatrist, these direct telehealth consults have shown to really improve the trust built between the frontline clinician and the Access Project, and to support that change behavior. Next slide. Want to talk about our webinar series. So this is our 2025 PeriPan webinar series. These are free continuing education credits that we provide. This is delivered statewide and with expertise from across all of our HRIs delivering these educational units. You can see that we have so far this year had physiologic changes in pregnancy and postpartum, just talking about what happens during pregnancy and how this changes the way medications are metabolized, and how that could dictate changes in medication dosages during pregnancy. We've talked about eating disorders in the pregnancy and postpartum period, ethics of treating mental health conditions in pregnancy and postpartum. And then upcoming, we'll have behavioral strategies and psychotherapeutic models of care for perinatal anxiety and depression. So really thinking about what are those evidence-based interventions that are not medication. And then you could see the rest of the series this year. We want you to encourage not only your Access projects to attend, but your partner clinics and any trainees. We have some really fantastic speakers from all of our HRIs, experts from across Texas who are delivering this education. And I would encourage you to have as many people as possible participate in this. Next slide. And then want to talk about our maternal health echo. We have collaborated this year through some HRSA funding with Be Well Texas to introduce to make sure that our education includes specific expertise and education around substance use disorders and substance use behaviors for women in the pregnancy and postpartum period. Of course, this is because overdose is one of the leading causes of death in the first year postpartum, in addition to suicide. So this is a very, this is nationally and in the state of Texas. This is a very important area of education and improving access for the women in Texas. We have, I should have checked this before I came on here. Well, I can't find it right now, but it's over 200 people. I'm sorry, 429 people are registered for this ECHO. So we're really excited about the energy that we have gotten around this ECHO series, in addition to having our Be Well colleagues already had a group of people coming to their ECHO. PeriPan had a group of people, and so we're having a much greater audience that we can deliver this education to, but also have experts from both the substance use treatment community and the perinatal mental health treatment community come together to share their expertise and experience and expand all of our capacity. So this is really exciting. And I am grateful for the privilege to facilitate this collaboration. Next slide. So please scan that QR code if you haven't. And these are the topics I want to say on the ECHO series. We have worked really hard to join the ECHO series with the webinar series so that the topics are basically partnering together. So we will first have a webinar and then 2 weeks later have the ECHO. Webinar we think of as more of a direct didactic teaching experience, where the ECHO, the Extension's Community Health Outcomes session, is more an all teach, all learn patient or case presentation, where we're really learning directly about resources within our communities and ideas that people have, whether we're in a rural setting or an urban setting, to providing the very best care for our pregnant postpartum women in Texas. So if you attend the webinar and get that direct didactic education and then come to the ECHO a couple of weeks later, then you'll be able to really participate in a deep and meaningful conversation. So we're really excited about that. And I am so grateful for all the collaborators for this project. It has been a labor of love for us to put together. Next slide. Just a couple of updates. So we march forward with our PCORI project with Lifeline for Moms called Pathways to Perinatal Mental Health Equity. This is the real goal here, is to help our PeriPan teams better understand some of the evidence base that came out of other projects in another state, where we learn how to help the actual clinic and clinic staff who are directly providing care to women understand how to screen, what screening protocols are, when to call PeriPan and when to utilize that service, so that we can create a more regimented approach to catching, addressing, intervening, and supporting women with perinatal mental health distress. These, we have 9 participating OB clinics across Texas. So across multiple areas in Texas, we're really excited about that. But the goal is that we will train our entire PeriPan staff and how to do this work, so that we'll really be able to support clinics in implementing our Texas AIM parameters to improve women's mental health care. And then the second is that we have a new program manager. So as you can see, we have lots going on in PeriPan, and Jen Erdigy has been, she is just amazing, and I'm so grateful to her, and she continues in her role, but we needed additional support to do a good job in doing all of these different things that we are doing. So we have hired a new program manager, Amy Lozano, and she will start with us tomorrow on April 1st. And it's not a joke. It is April Fool's Day, but it's not a joke. April 1st is also the day I became chair about 6 years ago. And so I always find it funny. It was also not a joke, although some days maybe it feels a little bit like that. But I appreciate, I'm excited for Ms. Lozano to join our team. And I think you all will have a great time working with her. She's very personable, very efficient, very effective. Next slide. I was supposed to say that Amy's going to support both projects, both access projects, CPN and PeriPan, and I forgot to say that. But that's all I got. Happy to answer questions.
All right. Jeffrey? Yeah, Sarah, by the way, my first day of work at Dell Medical School was also April the 1st, 6 years ago. So the joke's on both of us, I guess. So, absolutely.
It's a
wonderful.
privilege. It's a privilege.
Yeah, it's absolutely wonderful to see all the growth in Pan. And I will tell you personally, February and March have been the busiest months for me in terms of taking consults. I had as many as 4 in one afternoon not too long ago. I wanted to ask a couple of questions. One is in the balance of the consultations, those that are only requiring level 1, where they're seeking referrals, versus those that are needing the level 2 consultations. How has that balance shifted at all? And then the other thing I wanted to ask is the slide you showed with the provider types and psychiatrists now being 55%. I can tell you from my experience, and I've seen that shift as well, but the vast majority of those where they're mental health care providers, they've actually been psychiatric nurse practitioners. And I wonder if that's what I'm seeing there. And the implication of that is, I wonder if that's a group that should be a focus of enrollment and recruitment of those psychiatric nurse practitioners into Pan.
Great question, Rachel. Thank you so much for pulling this back up. So this slide actually does not reflect the people calling. This is the consultation type versus the level 1 versus level 2 that you were just talking about. And so there's absolutely been a shift, a really exciting shift. And I think for everybody maybe listening, I talked about, so what Dr. Newport refers to as level 1 is our mental health clinicians who are answering the phone or providing that first touch base of if it's a referral needed or a resource needed or something like that, that is what Dr. Newport is referring to as that level 1 consult, where the level 2 is really where it's transitioned to that psychiatrist for further diagnostic clarification or a medication related question. Or, is this an emergency type of question? Like how worried should I be about this? And so, yes, we have seen a shift of those, a very exciting shift over time, because that level 2 consult is where we see that change behavior based on other evidence. Happening more than the level 1. The level 1 is a service provided, but it doesn't actually dictate that much change behavior, really very little, if any, change behavior based on previous evidence base, although all this evidence base is fairly new, so I don't want to overstate it either. But the level 2s has definitely shifted. So that's a 39 to 40 and 55%. Rachel, I'm not sure if you can go back and find the how easy it is. Yep, perfect. Great. Of course you can. So this slide is really about the number of physicians that have called. So 64% of our callers have been physicians. And then of those physicians, this is the breakdown of what specialty those physicians are. So about 8% of the physicians have been psychiatrists. So this is not an overwhelming number, but it is interesting that our psychiatrists are calling more than our family medicine doctors. This may be because family medicine doctors in many areas of the state are not providing a lot of perinatal care. I live out in West Texas, where our family medicine doctors provide a lot of perinatal care and deliver babies and do all manner of things. And so it may be reflective of, in certain areas of the state that the obstetricians are providing a lot more of that perinatal care than the family medicine doctor. But I just thought it was interesting that our psychiatrists are increasing. We've seen this shift over the last few months, and I thought that was interesting. They're pretty close still. And to your question about whether we should enroll our nurse practitioner colleagues and our PA colleagues, absolutely. And we definitely are doing that. When we're talking about what mechanisms to track or what metrics to track, not mechanism, what metrics to track, this is a much more complex discussion than one might think. And so when you think about what kind of metric to look at overall, for peri-pan, we discussed that we would look at obstetricians as the metric. One of the reasons that we did that is because we knew that our pediatrician colleagues and our family medicine colleagues would be calling us in peri-pan, but we had already approached them for CPAN. And so we didn't want to automatically enroll them in peri-pan and then overinflate, over-represent our work, any work that we had done. Because if we can literally just say you were in CPAN and now also we're going to tell you about peri-pan and count that as a lot of work we done. It is work. It is still work that we're doing to retell our colleagues about peri-pan and make sure they know. But we wanted a distinct metric about new physicians who had never been involved in, or new clinicians who had never been involved in one of our access projects, and what our engagement looked like in that area. And so it made sense because of the perinatal population to choose, since we already have pediatricians and family medicine docs as metrics in the CPAN that we were following for our CPAN project, that we would identify obstetricians. This does not mean that obstetricians are the only clinician enrolled by any means. We enroll lots of different clinicians. The reason we have used obstetricians as the metric, or really physicians across CPAN and peri-pan, is that it has been the easiest so far, still not easy. I could tell you about all the meetings that we've had around it, but the easiest to define a denominator. And so when you look at the Texas Medical Board statistic or roles, that you're able to see this is how many obstetricians there are in Texas, and we can look at that each year. When you look at nurse practitioners or PAs or some of our other colleagues, it becomes very difficult to know who's providing what kind of care because of the way in which the documentation around their licensing. And so that requires a lot more front end work of like calling and verifying who provides what care. That work is already happening or needed as well, even when we're talking with our obstetrician colleagues. If you're a hospitalist, we are not going to target you for enrollment. If you're only providing gen care and not obstetric care, we're not going to target you for enrollment. And so there's still a lot of that front end work that has to happen from our teams about verifying and validating who actually should be in the denominator when we look at these percentages for enrollment.
To transition to the next section, but again, thank you, Dr. Wakefield, for all the work that you and your team are doing.
My pleasure. Thank you.
Let's go to the CPAN update.
Nuh-uh. TChat first.
TChat, okay.
Yeah, they just
Okay.
switch it up on me for fun. Okay. So TChat, next slide, please. So we continue to see growth in the number of referrals that we're getting across the state. The top line is the most recent year, our current year, school year that we're in, with the amount of referrals we're getting. Again, remember, we have that seasonal variability that's always sort of baked into working with children. Next slide. The next slide is moving from the referral. So as we talk about all the time in TChat, TChat is a service that family and legal guardians must consent to. So even though we get a referral from a school, we still need to talk to a parent in order to make sure that they would like to have the service. So there's always going to be a dip between referral and enrollment because it still is a choice that the families need to make with us. But nonetheless, that number as a top line is still increasing. The next slide. The next slide you see here is the number of treatment sessions and clients served by month. Try to say that 3 times fast. I clearly couldn't do it 1 time fast. And so that red line is the actual number of young people and their families that are involved in TChat, and the blue bar is the actual number of sessions. And as you can see, we're continuing to see growth. The evaluation teams would probably tell us the percent of it, but it still is a nice healthy growth from year to year when it comes to the number of services that we're helping across the state of Texas for TChat. Next slide. This slide should also be very familiar to you. This is a slide that sort of shows the type of team members that are involved in helping children and families. And again, because most of the evidence base for treatment of children mental health concerns and issues is a psychotherapy, our largest percent of our sessions are involving our therapists as well as our case managers, and a much smaller percent are involving our physicians. So that's not changed. And then the slideshow didn't end, at least for me, but here it looks like it did. So I'll wait. Okay, well, some slides got kind of left off, but we can keep moving to the next set of slides, whatever that might be.
And Rachel, do you have the governor's report?
Okay, so this is our TChat school enrollment data as of January 31st, 2025. You'll see that we are active in 75% of all campuses across the state, and that represents 78% of the student population. Here is a proportionate view by HRI. We have 451 schools with an onboarding date with an onboarding status and 236 date. You can see most of those will be onboarding hopefully in September. We saw growth in active campuses in 7 ESC regions this month. And we continue to grow over time. And then finally, the primary reason why schools decline is because they have existing mental health providers. Any questions here? Yeah, we win.
Good morning. Yes, a quick question. You know, Dr. Lakey, you had mentioned earlier the rider that had to do with looking at if TChat provided more than 4 sessions, you know, the potential of having to, you know, do an analysis of what the impact would be for billing, Medicaid, or other third-party commercial insurance plans. Do we know what, when I look at these numbers, this is incredible. Do we know out of the children who are served in TChat, how many get beyond the 4 sessions so that we would have some idea of the potential impact on that particular rider for the children that are currently enrolled in TChat?
We have that data. We track it pretty closely. I don't know if Rachel can pull it up right now. The number of sessions that are beyond 4 sessions.
Well, I can follow up with you later, Luann. I know that the average is about 5.
Yeah.
Okay.
We were trying to manage so that 80% of the children would be served with 5 or less, and have about 20% that were beyond that. We're somewhat close to those numbers, but we can pull you the actual numbers. And again, the nice thing about the rider is that it doesn't say you shall go bill. It says that we do a thoughtful analysis of what it would take to do that. And so, you know, give us the time to really work through those numbers.
Okay, thank you.
Thanks. Olga?
I've turned on my camera, Dr. Reddy.
Very good.
Sorry, Dr. Lakey. Can you go to the next slide where it says why folks don't enroll, Rachel? Or yeah, I just wanted to see what the other HRIs were finding. We are finding that school districts that had traditionally said that they did not want to enroll because of existing mental health providers. The demand is so high that now they are reaching out to enroll. Are any of the other HRIs experiencing something similar? Or are your no's or your historical no's still no?
I don't think we're really seeing that in our area. And as I look at the list here, it looks like a lot of these schools that have existing providers are in our area, with Dallas being, of course, one of our biggest. I see that you also have the Houston district in there, but some of these are very large districts in our area with lots of campuses.
And we've shared, Olga, that information with the legislature that, again, as was just noted, many of the large districts in Texas have mental health services that were funded by their local ARPA dollars.
Mhm.
And the concern that those local ARPA dollars will be going away. And not only the demand that you noted, but again, the support that they have for those services being transitioned, and our expectation that that may drive significant increase in volume for our programs.
Thank you, Dr. Leakey.
Dr. Leakey, I think Molly has a follow-up on Luann's question.
Sure. Just to close that loop, we have 22.4% of students who receive more than 5 encounters as a part of their therapeutic episode of care.
Okay, thank you.
And Sue, I see your hand up. Is that from before?
No, just
Okay.
going to add that we did have several contacts with Alice again. Post, when we thought the ARPA funds were going away, and they were having the district make up that loss. So to continue with all the people they had hired. So we've only been able to add a few more campuses with them.
Okay. Very good. Any other questions or comments? Hearing none. Now, Laura, I think it's time for CPAN, right?
Potentially, but I would say that we never say no. So if a school district has previously said no and they reach out, our team still will figure out a way to help them out. So we remain available. CPAN. Next slide, please. So a similar story to the perinatal access team. We continue to see growth within our CPAN. As you can see, this time last year and versus this year, this month for this year, we've had continued growth of the number of phone calls that we have received. Those total access enrollment numbers of providers both include the perinatal and the CPAN type, as well as the number of clinics are combined here as well. We do continue to have most of the consultation requests be about a patient, and we continue to be able to get those calls back within 30 minutes or less as the physician requests. We also, of course, have the opportunity for the physician to say, I need another time to get a call back, and then we work to make sure that we get that call back at a time that works best for that provider, that clinician. Next slide. This is just sort of looking at from the last several years. And of course, the most recent year that we're in is the one on the top, which again, we continue to see growth from year to year in CPAN. Next slide. So this is a similar slide that we spent some time on with perinatal, which is the number of calls that include the psychiatrist. As Dr. Wakefield suggested, our goal is to hopefully be around that 35, 40% mark when it comes to sort of our psychiatrists having a conversation with that PCP. So we continue to sort of see that, and we're glad for it. Next slide. This is the one that I did want to spend a little bit of time sort of talking about. So this is the direct consultation slide. And as you can see here, we're also very excited to see that number from month to month has continued to grow. One of the things that's very specific and unique about the effort required in the direct consultation is that it is, once again, the PCP and the psychiatrist discuss it on the phone. A decision is made where we say, hey, I think a direct might help this family. The PCP will either say yes or no. We actually are tracking how often they say yes and how often they say no to us. And then the next step has to, again, be a parental permission. So then we do reach out and ask to see if the family would also like to have that direct consultation. And we have the ability to also track how many times a family says yes and how many times a family says no. And then this here is actually how many that are actually done. A direct consultation is much different than, of course, than that phone conversation that's, very brief, 10, 15 minutes max usually. This is 2 hours plus, sometimes closer to 3 hours because you spend an hour and a half possibly with the family, another sort of amount of time creating that consultation letter, and then a call back to that provider to actually educate and teach them on what we learned from that appointment. So it's a significant amount of time, and you start to just do a little bit of math, sort of looking at 129 of them, even just say conservatively 2 hours, is starting to take up a significant amount of our psychiatry time, which we're wanting to have happen. But it is definitely, as we see this growth, we are starting to see how we have to make sure we're really planning across the state. And we're one large team. We're not 12 individual teams. We're one large team. So there's a lot of coverage going on across the state from each HRI needing to pitch in and help when one of the other hubs is doing a direct consultation. So just wanted to point that out, that we're definitely seeing a significant growth here, which is what we're excited for. But with that requires more planning and organization. So good work, everybody. Next slide could be, this could be the last slide because my slides were different. So done. Oh, I can? Okay. I thought we were only supposed to talk on the things that were on the slides. So, so yeah, the one thing that I just briefly is we are working towards having the release of that PCP portal. So one of the things that we heard from, physicians across the state, clinicians across the state is obviously how busy they are in the day. And so they would like to have a way where they can potentially asynchronously turn their consult question in. So we have been working to have a portal that will be sort of the created and available starting this summer. And that will allow for the physician and or their team member to go into a secure portal, put in the information, maybe after hours, and then we would see it the next business day and work on it. It is not an asynchronous consult. So let me be clear. It's an asynchronous request for help. And so we're hoping that that will also help drive up our consultation numbers. There'll be additional sort of ways that the portal will assist PCPs. They'll be able to see the direct consultation findings. They'll be able to see just the actual telephone findings. So there will be additional features that we think will really help those PCPs. That was some of the things that they requested. And this is, of course, one of the reasons for why we're working to build it. This was one of the, I think, really great uses of the ARPA funds, was this one-time kind of creation and build of this process to allow for us to get consults in asynchronously. So excited to see that roll out, and we'll have more to say in the summer.
Very good. Any questions? Luann?
Well, I just want to say kudos on that portal, because I think that is a fantastic thing that's going to be extremely helpful to providers. So let us know when that rolls out. I'd love to see a demo.
All right, very good. Laurel just gave you a thumbs up. Very good. Any other questions or comments? Hearing none, let's transition then to the internal evaluation update. And Dr. Lopez. Oh, research. I skipped over the research update. Sorry to skip over the okay.
So this is related to the new and emerging child mental health researcher grant. Just a few updates on it. We extended the deadline for the pre-application process to April 4th. So that's a week extension. And part of that was because we weren't getting all institutions to have applicants submit to us. And we wanted to make sure that we have sufficient number of applications and participation from all of our institutions. So that would mean also that we would be notifying applicants a little bit later. Now, we may be notifying some applicants earlier, depending on the scoring and ranking that's done by the chairs of psychiatry for certain institutions. And so we will notify applicants as we get those review processes by our chairs of psychiatry. And we're going to be leaving also the full application deadline to May 16th. And we'll re-review that. But we just a little bit idea of how many applications we've received as of yesterday evening. We received 40 applications. 32 of them have been fully submitted and 8 are being worked on and are pending. Those applications represent 8 out of our 12 institutions. So we have 4 institutions that have not had any applications submitted by researchers within their institution. Also, we have 2 institutions that represent only 1 applicant or are represented by only 1 applicant, and then 1 institution with only 2 applicants. remember we talked about limiting institutions to about 6 each to get about 72 applications. So if we don't get applications from or to that level from certain institutions, we're going to open it up to more applications from other institutions that have more applicants from their institutions. The remaining 5 institutions have 5 to 10 applicants that have submitted. The other thing is I just got an email actually while we were meeting, somebody having issues getting on and putting in a new application. So if anybody has any issues with the software, let me know as soon as possible. I'm also the person who's fixing the software. So, and just be patient with me as I kind of navigate that with the consultants for that software. But please let me know as soon as possible so we can resolve that. The other thing I want to let you know is we have 7 of our 10 reviewers have consented to reviewing again. This is the external review, so from states outside of Texas. And we've asked all our chairs to identify an additional 3. So we usually have about 10 external reviewers. So we'll be going through those and inviting 3 additional reviewers. We also have 3 Texas reviewers who represent HHSC and nonprofit who've already also consented to be part of that. So very excited about that. So over the next 2 weeks, the chairs of psychiatry are going to be prioritizing and scoring the pre-applications. If you have any issues also accessing the system or navigating the process, please contact me and I will be assisting you. We can schedule some time and to make sure that all applications are scored and prioritized so that we can invite them for full application. That is all. Any questions?
Doug, let me just say, the software works great. So I've done a lot of grant reviewing in my life, and sometimes the software kills you. But in this case, it was seamless. So nice pick.
Thank you. Any other questions?
Any other questions?
Well, thank you.
Yeah. So again, you know, for the chairs, need to make sure that you have attention on this over the next short time period, and we can accept more applications. You know, the amount that we're going to be able to fund will be dependent upon the dollars that are put in by the legislature, but there are dollars that we have allocated for this, and so I look forward to seeing the applications and being able to fund some young investigators and build the bench here across the state of Texas. Now it is time to Dr. Lopez for me to transition over to you.
Right, thank you. I'm going to share just a few updates of some of the things that our team is working on. So one of the things that we're very excited about is we've been working on 3 presentation dashboards, and those will provide HRIs with some key visualizations across TCHAT, PeriPan, and CPAN that can be used for presentations. So those dashboards will provide you with both HRI specific visuals as well as state aggregate visuals. So you'll have access to your own data and then some of the state aggregate data for presentations that your teams may be doing. As a part of this, we are preparing slide deck templates that will have key information and some notes on data, how the data was developed, kind of what those key metrics mean in case you have any questions. And then you'll be able to take screenshots of those visuals and load them into your slide deck so you'll have the most recent data. The dashboards are going to be updated monthly based on the latest data that we have from TRAIT or any other data systems that we may be using for that. So we're really hoping to roll out these presentation dashboards over the next few months. TCHAT will probably come out first, followed by CPAN and then PeriPan. Another thing that we've been working on is preparing a survey that will gather some feedback from the executive committee, from program leadership, and then program providers at each HRI really to dive in and understand their experience with the consortium's administrative functions. So, for example, the role of the medical director leadership that we talked about earlier, support by Kosh, and then our technology solutions, those various things that are put in place to really help teams hopefully be as effective as possible. And we really want to also understand ways to continue to improve those statewide supports, as well as any additional barriers that may be experienced, that there may be some opportunities to address at a statewide level. And then the third thing I want to share is we've also been working with the TCHAT and LMHA pilot project that you heard about a little bit earlier today to understand how we can best evaluate that pilot and learn from those programs that are working to develop those collaborative processes for transitioning folks. So we're really looking forward to understanding what they learned from that and being able to share those best practices across the HRI more globally.
Any questions for Dr. Lopez? Hearing none. Cynthia, let's transition to you.
All right, thank you, Dr. Lakey. Again, my name is Cynthia Smith. I am the Salesforce Administrator for Internal Evaluation in Austin. I'm going to provide just a very brief update on the status of our Salesforce implementation. Good news, the database is going live tomorrow, April the 1st. Again, not a joke. It is going live tomorrow, and we are thrilled to finally be able to make this resource available to the HRIs. In preparation for that rollout, we did host a series of end user training sessions throughout the month of March. If there are individuals who were unable to attend some or maybe even all of the training sessions, please know that those session recordings along with the slide decks are available via SharePoint. That being said, if you have anyone on your team who comes to you and says that they feel as though they could use some additional support with Salesforce, please remind them that they can reach out directly to internal evaluation. I'm more than happy to host small group sessions to help individuals get more familiar with the platform and to do deeper dives. Okay, so the main topic I wanted to talk about today in terms of our update is around HRI reporting requirements. So as a reminder, the first phase of our Salesforce implementation is focused on two things. So one, TCHAT enrollment. So what is the status of MOUs? Has a district declined? If so, what is that decline reason? Is a campus moving from pending to onboarding? So all of that data is going to be captured in that first phase of our Salesforce rollout. The second part of our focus was around outreach and training. So if I am PeriPan and I have gone and tabled at an event, I would want to be able to log that activity, right? So the date of the event, what was the maybe topic of discussion, was there a co-sponsor at that event, and also the date. So those were the two focus areas for phase one of our implementation. And the reason that we did that was because we were trying to eliminate the two spreadsheets that the HRIs are currently submitting for monthly reporting. One is the campus recode spreadsheet. That spreadsheet is focused specifically on TCHAT enrollment. And then the second spreadsheet is the professional development and outreach spreadsheet, which is for all outreach and training for consortium-wide programs. And not just TCHAT, right? So CPAN and PeriPan as well. So we focused on those two areas in phase one of our implementation. In terms of reporting requirements, the final spreadsheets were submitted by the HRIs on March the 15th. That was for their February 2025 data. The next round of reports are due April the 15th. That is for their March 2025 data. And those reports are due in Salesforce. So just wanted to be clear that the spreadsheets have gone away. The final reports were submitted on March the 15th. On April the 15th, those reports will be submitted via Salesforce. So just in summary, database goes live tomorrow, April the 1st. Final spreadsheets were submitted March the 15th. Next reports are due April the 15th, and those are due in Salesforce. That's all I have.
Very good. Any questions? Hearing none, let's go to the update from external evaluation. Ms. Havas?
Yep.
Thanks. So I'm going to give a brief verbal update as well. Beginning with some of the activities we've been focused on. One is the economic evaluation and aligning the cost survey with the UT, working with the UT system leadership to ensure it's aligned with consortium needs, and revising the cost analysis approach and with that collaboration. And this emphasizes tracking personnel effort across key activities such as clinical services, recruitment, training, at the HRI level. And we developed a revised survey instrument to improve the cost reporting consistency across both CPAN and TChat. And our next steps are finishing that data collection and analyzing that data. In terms of TChat, we also have a TChat survey that we've developed for the fiscal year 25. This is a campus survey to assess program implementation and factors influencing the school engagement with TChat. For example, program needs, barriers, use, participation in specific TChat activities, and perceived outcomes by those implementers. The survey is now being finalized, and we'll be sharing that with UT System and Kosh for feedback as a final step. And then we're also currently building a sampling frame to capture a representative group of users across HRIs in consideration of school types, geographies, rural, urban, school size, and then the next step is in April, we plan to distribute it so we can get those schools, get people in schools before they leave for the summer. The CPAN survey goes through a similar process. So we've developed a survey to assess factors influencing engagement with the program, including program needs, barriers to use, organizational factors for context, and participation in activities and perceived outcomes. And the survey is also in a final stage, and we'll be sharing that with the UT System and Kosh for feedback as well. Again, we're going to be developing a sampling frame, which we're almost done with, to capture a representative group of recent users across the clinic types and geographies. And the next step is to plan the survey, which we're hoping to distribute in May. So we analyze these data over the summer so that we can get the reports in the fall. The next one I'll talk about are HRI interviews. And this is when the beginning of the program, when it was first being rolled out, we did a lot of process mapping to understand what are the implementation strategies being used by across the different HRIs. And we're going to do some in-depth interviews to gain more understanding of updates to these implementation strategies. So we've completed development of the CPAN and TChat HRI interview guides. These are going to be focused on assessing what are the program activities, including training, implementation strategies for onboarding and engaging clinics and schools, challenges, best practices, and opportunities for treatment and implementation. And then we'll use these, we'll analyze these and use the data to help inform quality improvement. Our collaborators on the external evaluation, the Decision Information Resource, DRI, are helping us reach out to plan the interviews with CPAN and TChat implementers. And these will be with clinic leads, program managers. We're asking for about 1 to 2 people from each HRI to participate. And then another activity we've really been working a lot on the most recently are updating the logic models so that we have, we're sure the roadmap for the evaluation plan is aligned with the goals and the priorities and going to be aligned with understanding performance monitoring and outcome measures that are the priority areas for the consortium stakeholders. So we've been working with the internal evaluation team to refine and update these CPAN and TChat logic models. We've also developed or revised our measurement plan to align with these logic models to ensure that the key outcome metrics are matched and align with the priority process, implementation, and outcome measures. And defining them so that we're all measuring the same thing or calling the same measure the same thing. And we plan to share these updates and work through the future finalization of the measurement plan with consortium stakeholders, including the internal evaluation team. And those are our major targets.
All right.
So
Any questions?
questions?
All right, hearing none. One quick item before we move further, Dr. Elephant, I see that you have joined us, and so I just want to make sure that the record captures that. Is there anybody else that has joined us, the members of the executive committee, that we don't have down as attending? All right. Hearing none, let's transition to the communications update. And Melanie, I saw you just a little bit ago, but let me turn the podium over to you.
Hello, it's nice to be here. Thank you, Rachel. I'm gonna move this to my larger screen, so I'm gonna be looking to the side. Okay, so I have a few slides to share with you, different initiatives that we have been working on for CPAN, PeriPAN, and TChat. Thank you, whomever is doing the slide. Next one. So what I'm going to talk about today is some of the initiatives that we've been working on, interviews with priority audiences, a large effort that we've had in collaborating with key stakeholders, show you some of our social media analysis and some of the materials that we're working on that largely support what Dr. Williams and Wakefield spoke about earlier today. Next slide. Thank you. So we spent some time this year talking to our priority audiences. One, to gather information, and then also we like to do this when we're creating information to field test materials so that we know what we're creating is appealing and motivating for the priority audience. The first group that we did, what we did with PeriPAN was we interviewed 15 OBGYNs who were enrolled but not using the program or hadn't used it in several months. And we wanted to learn from them their thoughts, impressions about the program, and also go over some of our program attributes to get their opinions on them. So when we interviewed them, it led to some of new creative materials. One that we're still working on is a certificate of sorts that they would be able to show in their offices that they are a mental health friendly clinician and show that they're part of CPAN, PeriPAN. So we're working on those designs right now, along with a process for the HRIs. And we'll start with a pilot for that, just to make sure we have our process down really well. We heard resoundingly from the clinicians that texting and the direct consults are really, really interesting and helpful to them. So we created 2 short animated videos that we'll be using in our digital campaign starting in May, June, and July. And also we'll post those up on social media. And I think that Anissa already put them on our YouTube channel. And they're just quick 20-second animated videos about both of those initiatives. This also helped us, these interviews, with our stakeholder outreach, which I'll talk about in the next, when I get to the next slide. For TChat, we interviewed counselors and parents to learn perhaps any barriers, if materials were working for them, and what they needed. And out of that, we created a parent-specific flyer, a teen flyer, maybe middle school, high school flyer for them as well. And for the counselors, we heard a lot from them, and we just finished interviewing them in a field test capacity. We created a robust FAQ document for them And it is about to be released. So we'll be handing those over to the HRIs soon. Next slide. I still see the same slide. There we go. Thanks. So one of the efforts that we have spent a lot of time on this year is engaging and spending time with and really working to have a deeper level of collaboration with key partners around the state that can help spread our messages to their clinicians. Here are logos for the different groups that we have been working with. We do create newsletter content. We give it every month to TPS, who then sends it out to their constituents. And on a quarterly basis, we provide content for other collaborators to share with their constituents, whether we're tagging them in social media or we're giving them specific information to share with their groups. This is something we also heard when we did the physician interviews, when we asked them, you know, what is a motivating factor to learn about a new program? And for the OBs, they said anything that ACOG says is something that we'll pay attention to. So ACOG has been a wonderful collaborator with us, and they share information at their meetings. They send it out to their constituents. We've done a webinar together, a little 10-minute webinar on our toolkit, and post there a joint little video that we took at a conference on our social media slides a lot. So one of the things we also did, I want to draw your attention to NARCAD, which is an Association for Academic Detailing. We heard from the physicians that one of the many ways to engage with them is coming out to their offices, which we do. I know that it's time consuming. And this training, each of the HRIs have been going to and learning from some best practices on how to do that. We've had some really good engagement with that. We do send content information to the nurse practitioners. The first newsletter that they'll get with content from us should be going out in April. And for the Texas Association of Physician Assistants, we have been going back and forth with email, and we're going to meet with them this week. So we're just really working with our collaborators on moving everything that we're doing forward to their constituent base to amplify the messages and gaining interest and utilization of these programs. Next slide. These are just some examples of the collaboration that I was just speaking with. On the right, you can see the TPS newsletter that goes out. You can see for TSPP, we have Dr. Balafons is the president, I believe, of that organization this year, and also worked with us and created a newsletter content piece about PeriPan and how the organizations can work together. ACOG put a definition of PeriPan in their glossaries that they give to representatives to the legislature, and there's another example of an ACOG communication about our program. So we're just so thankful for all of those groups and organizations to carry our messages forward. Next slide. Here's some of our social media. I just wanted to show the reach that we have between LinkedIn and Facebook. About 45,000 people are being reached. Then we see our growth for LinkedIn, almost 40%, and Facebook, 12%. Some of the messages, the way that we try to work with the social media is to share program attributes like texting and direct consult and the CMEs and provide that education. You'll see some of our top performing posts. One was about the Safety A suicidality intervention training, our perinatal mental health toolkit, always does very well. And on the right, on the bottom there, you see the video with Dr. Olson from ACOG and Dr. Wakefield talking about us working together. So if you don't follow us yet and you're on this committee, please do. When you all engaged and put messages forward, we see that clinicians also engage. So thank you. Next slide. Here's some of the creative material we're working on. This is TChat based slide. And one of the things that we did with TChat is we created a content library and a style guide and shared that with the HRIs at their request. So they have content and language to draw from when they're speaking that has gone through appropriate recommendations. And so we speak the same language when we're talking about services. And over here, you can see some of the materials. We've also translated the parent and child flyers into Spanish. And we are also in the midst of translating each one of those into a different language, Vietnamese and Mandarin, I believe. So that's some of the creative work that we've done for TChat. Next slide is some of the creative work we've done for CPAN and PeriPan. You can see we've also translated into Spanish the patient-facing PeriPan mental health toolkit materials. And when we were doing the interviews with the clinicians, they spoke about it would be nice to have all of those materials in a booklet. So we're on the final stages of creating that booklet, which is also going to be translated and also will be on our website. And here you see the top icon over there is a draft of one of the concepts for the certificate that I spoke of. And there are just some screensavers for the videos that I mentioned about texting or direct consult. Next slide. I think that's it. That's it. Thank you so much. It is an honor and a privilege to continue to be able to work on this program. And I'm happy to answer any questions.
Thanks, Melanie. Any questions, comments? All right, I'm not seeing any, but again, thanks, Melanie, for all the hard work. We're approaching 12, but I think we can finish within 30 minutes. So we're just going to go ahead and push on. And but I have two what I think are going to be I think we're going to be really interesting and engaging presentations where we've identified a couple of projects, institutions that are doing things with the ARPA dollars, some partnerships between universities, and thought it would be nice to spend some time just sharing those examples with the rest of the executive committee. And so we're going to start off with UTRGV. And Dr. Chapa, let me turn the podium over to you.
Thank you, Dr. Lakey. And I think it's still morning, so good morning, everybody. So yeah, I just am going to briefly share how UTRGV has benefited from the partnerships that we have with some of our sister institutions. Of course, as has been mentioned by Dr. Williams, we are all one team. So because we are part of the consortium, just through that, here at UTRGV, we have benefited from getting support from our sister institutions for coverage, like Baylor and San Antonio in particular have provided coverage for CPAN for us. The reason that we here at UTRGV are very grateful for all of these partnerships and the support that we get from our sister institutions is because we really have continued to struggle in being able to recruit faculty. So we want to, of course, remain involved. We want to be able to provide the care and, do the best that we can in being able to provide mental health care to to the region here, but to be fully honest, it has been a challenge just primarily due to the difficulty we continue to have with recruitment. I know it was a while back when we had our last psychiatry chairs meeting that I brought up how it was also becoming a challenge to be able to provide didactics to our residents because, again, we just have very limited faculty. And of course, we all want to provide our residents with didactics from experts. And Dr. Brenner met and got us started. And so we, this year, were able to get some lectures from UT Southwestern providers, which was very nice and very helpful to our program. Because again, the lectures are coming from those with expertise. And so the lectures have focused on predominantly substance use. So that really expanded the number of lectures that our residents were able to get. We were also trying to work to see if, again, from UT Southwestern, we could get a lecture in geriatrics for our residents. And that was something that we were not able to work out this year, but I, again, remain hopeful that the experience that we've had and what we've started will continue next year. And so that, again, that would be another area that we could work with our sister institutions and be able to bring those with expertise in the area to provide some didactics to our residents. We also got some help from Texas A&M. And so they provided one lecture to us. So again, I cannot say how much I truly have appreciated this and that you stepped up, Dr. Brenner, to help us get connected because it has been very helpful. And again, also, as Dr. Wakefield mentioned earlier, even though it wasn't through this initiative, just being part of the consortium has also been very helpful to those of us, small institutions who continue to try to recruit and want to provide the best training to their residents, to have, again, the ability to access some of the information, like, for example, the webinars that Dr. Wakefield mentioned. Again, our residents can go ahead and have access and then again get information on maternal and reproductive health, which is very important because, again, we do continue to see quite a bit of that. So we also, outside of getting help with didactics, as I mentioned previously, just through being part of the consortium, we have had help from San Antonio and Baylor in covering our CPAN, but we've also been able to work in partnership with, again, UT Southwestern to provide us with a faculty that can help supervise our residents as we continue to provide care and services to one of our LMHAs. So that's been good. We had to shut down for a while because we did not have enough faculty to meet those needs to the LMHA. And now we're back on track with, again, the support of UT Southwestern. So the only other, with regard to ARPA, Dr. Lakey, the only ARPA initiative that we have here at UT Southwestern is PeriPan. So we were very grateful that we were selected in this case to be one of the early HRIs to try this out. And so we've been working with PeriPan for the past 6 months. And in those 6 months, We've been able to enroll 47 clinics, 178 providers, the majority of which are doctors and MPs. We do have a couple of PAs and one nurse midwife. And we've received a total of, in this 6 months, of 89 calls. So again, it's been great to have the support of our colleagues, such as Dr. Wakefield and her team, so that when we get these calls, we've been able to forward them to those that have expertise. So really, it's been great to be able to leverage the expertise and in our sister institutions, because it really has done a lot for us here at UTRGV in our ability to continue to train our residents and keep our residency program open. And also it has been most helpful in allowing us to continue to meet the mental health needs here in the Valley.
Very good. I think this is a great example of kind of the partnership that's developed through the consortium, and that not all our institutions are the same. And I've worked at a smaller institution. It's hard. You don't always have all the other resources that you have when you work at the big institution. But by developing those educational partnerships, the clinical partnerships, the didactic things that we talked about, the development of new programs, bringing PeriPan there with the assistants and the echoes, et cetera, it really helps all of our institutions to do things that they wouldn't have been able to do on their own. And again, Dr. Chapa, thank you for all the work down there championing your community and bringing these resources and these opportunities there. And I hope with this and with the building of the residencies and all those type of things, that some of those workforce challenges that you're facing there over the long term are going to be addressed because of the work that you're doing. But thank you for doing that.
Yes, thank you, Dr. Lake. And I remain hopeful. This year, we were very proud to say that 12 of our students here at the medical school applied to our psychiatry program. And so again, that just shows the work that we continue to do and how our students are enjoying the rotation. And I think it sparks their interest in psychiatry. And now I'm hoping they choose to stay here.
Yeah, that's so important. Thank you. Adam?
Well, Dr. Chapa, first, congratulations on your match. But getting back to the didactics, I will look into what the obstacles were that we met around the geriatric didactics. So sort this out and I'll get back to you soon. Thank you.
Yeah, thank you, Dr. Berner. I appreciate it. I think what it was is just really trying to find dates that would work for both of us. I don't think it was anything more than that, but now we're planning for next year. So again, I do hope, because we've really, like I said, appreciated this. So thank you, Dr. Berner.
Yeah, I think this is really unique, and it's just not within one system, but it's A&M and it's Baylor and Texas Tech plus the other UT institutions helping the smaller institutions. And so again, thank you all for that willingness to serve in that way. Very good. Next, Dr. Wakefield, I'm going to go over to you. And I had the opportunity to spend some time with Dr. Wakefield up in Lubbock, it seems like a month and a half ago, and hear firsthand a lot of things that they're doing, and was impressed with a lot of the workforce initiatives that they are a part of, and kind of the whole we talk about the pipeline, but seeing it there in action through ARPA and the other programs, I thought was really well done. And I thought there would be value of having her share some of that work with the rest of the team. So Dr. Wakefield?
Yes, thank you for this opportunity. We have definitely had the privilege of taking advantage of some dollars through the American Rescue Plan Act to build what I would think of really as pipelines to recruit and retain really great individuals for training programs in West Texas. And I think I'll demonstrate in just a minute how successful that has been in a very short amount of time. And it has been a pretty heroic effort from multiple of our faculty and administrators to try to put all of these things together. But we were encouraged and excited to take advantage of this opportunity because we need it. We need it. It's hard to recruit to West Texas. And I think once people get here, they love it here, but it is probably one of the harder places to recruit in Texas. So wanted to share with you guys what we have done. Of course, we already had our child fellowship through the original consortium statute and our GR funding. We had started our child and adolescent psychiatry fellowship, which was really exciting. And when we had the opportunity to expand that with the ARPA dollars, we said, let's recreate that for our psychology counterparts and our licensed mental health clinician counterparts. It's not just hard to get psychiatrists out here and child psychiatrists, it's hard across the board. And we saw this as an opportunity to increase our ability to increase the training level and expertise in evidence base across our region for multiple different specialties. So I'll start with our psychology counterparts. Dr. Mitchell, who is also on this call, and our other executive committee here from Texas Tech was instrumental in this, but she has, and we have together started in the last few years, both a post-doctoral psychology child fellowship and a pre-doctoral internship for child and adolescent psychology training. So our fellowship got started first, mostly because it requires less accreditation steps than the internship, but we started the work on both at the same time. So fellowship, we have graduated one fellow who finished a 2-year program, and she was retained as faculty. We recruited another 3 postdoctoral fellows for this year who will finish, and all 3 are interested in faculty positions. This is 100% of our postdoctoral fellows staying in the state of Texas and currently planning on staying in West Texas to really change the whole landscape of child and adolescent psychology, mental health, therapy training, and delivery and access for our region. So really excited. And we've matched an additional 2 postdoctoral fellows for the upcoming year. When we look at our internship, so the internship had its first year. If you've ever been involved in a psychology accreditation process, it to me was more complex than the accreditation process for our child and adolescent psychiatry program. You have to set up all of the infrastructure for the internship. You then have to match interns or match graduate students into that internship before being accredited. So you have to find people willing to come to a non-accredited program, and then have at least 2 of those in there for the accreditation site visit. We did that. Dr. Mitchell did that. We set up the internship, matched 2 interns. She was writing letters to everyone to recruit really great interns, and we got fantastic interns. We went through our accreditation site visit. It seemed very successfully. The final decision will come to us in April. 100% of our interns are staying in Texas for fellowship, which is really exciting, and came from out-of-state programs. One of them came from out-of-state programs. And then we have matched 3 interns going forward for the next year. So a really, really highly successful in a very short amount of time program where we now have a pre-doctoral internship and a postdoctoral fellowship. Why this was really important to me to develop this program is that Texas Tech University, who we share a landmass with out here, has a fantastic program for child and adolescent psychology training. We have hosted graduate spots for those child and adolescent practicums for the last few years, and they were really excited and really great candidates. And then we sent them off other places for the final stages of training, often never to return. And this has given us an opportunity to have those return. So our two of our postdoctoral fellows, those very first postdoctoral fellows, were graduate students who came, who rotated with us in a child practicum, and then went off because we did not have at that time a predoctoral internship, went off elsewhere for a predoctoral internship, returned to us for the postdoctoral fellowship, and planned to stay as faculty. So you can see how important this can be to have our final stages of training. There was no other child and adolescent psychology internship or postdoctoral fellowship for our region. So these were the first, and they have been highly, highly successful. We did the same thing. We tried to model the same thing for our licensed mental health clinicians. There's less infrastructure in the exact training process, but we set up training across day treatment, outpatient settings, even in TChat and our employment assistance programs. And we set up multiple different training opportunities for our licensed mental health, marriage and family therapy, licensed professional counselors, licensed clinical social workers, and our licensed chemical dependency counselors. To provide them exposure to evidence-based therapies, exposure to expert supervision, time for training opportunities, didactic learning, and it has been really successful. We are retaining lots of clinicians through there that we know have great training, and then those who are going back into our communities are going back with really expert training to increase the capacity and the evidence base in care delivery for our entire region. So we've been really excited about this. We are anxiously awaiting what happens in conference committee, because we think this has not only increased access to care for our children and adolescents and families in the short term, but that it will increase our evidence base and care delivery for our entire region for children and families in the long term.
Very good. And again, it was very exciting to be up there not too long ago and talk to these young folks. Many of them didn't know much about Lubbock several years ago, and now are really enthused about spending their career at Texas Tech, and interns and fellows, and they're actually out seeing patients, doing a variety of things. And this is, again, I think a critical part of our long-term strategy of addressing the workforce needs. And so thanks, Dr. Wakefield, for all the work that you put into that.
It takes a great team. I'm glad you got to come see it. We have some great trainees and fantastic faculty and clinicians. So it's a privilege, as all of this work is.
And as Dr. Wakefield noted, these are in our budget, that area related to workforce, these are the type of projects that are funded by those funds. I realized that I skipped over one thing very quickly in the communications. I have a little line here that says to remind me to go to Anissa afterwards. And so about an update on the communication policy.
Yeah, I'll just share some reminders on the communication policy. So all external facing communications sit on behalf of the consortium or initiatives must be submitted for review by the UT system and other relevant experts as necessary. To ensure sufficient time for review and consultation, all communication materials must be submitted at least 10 business days before the intended distribution date. The consortium communications team will provide edits or approval within this time frame. And then lastly, HRIs are expected to review the suggested edits and resubmit the materials for final approval.
Okay.
Thank you.
Thank you for doing that. And again, trying to make sure that we're consistent with the brand and messages, et cetera, across the state. And so it's important for us to be able to put our eyes on it, and we'll try to be as effective or efficient as we can to get that information back to you. With that, I think we have completed all the items on the agenda. Steve, I see your hand.
Yeah, just a quick point. We're going to clarify this communications issue with how it interfaces with the data committee, because they're two separate things. The communications group kind of looks at the brand and the language and how things are phrased. Of course, the data committee just looks at the integrity of whatever data that you're going to be presenting. And so if you have a situation where you're presenting data, there actually are going to be two processes. You'll present it to submit it to the data committee for review, and then it may need to go on to communications, particularly if it's a poster that's going to be presented at a public facing meeting. But we'll be getting out some memoranda that will clarify those two aspects of the process.
Okay. All right. Any other questions or comments? All right. Seeing none, again, thank you all for your time and look forward to talking to you again next time that we meet. We'll have better clarity related to the budget. But again, would ask individuals that if you start getting messages from me in the next several weeks, I will need you to respond to me very quickly because the messages and questions that I'm getting, I need to ask you to get input on as these different bills and budget items get crafted. And then again, another homework related to the research. Again, the chairs, please encourage individuals to get their applications in as quickly as possible and start the review process to make sure we have good people that we can fund. And with that, I think we're completed. Thank you.
Thank you.